I'm next going to talk about value of new cancer drugs and how we define this in our setting. First, what is value? Value is defined. First of all, we're not talking about value-based care here. There are two types of healthcare: value-based care and volume-based care. That's different. Today, we are going to talk about value-based pricing of cancer drugs, and that is defined as benefits per unit cost. So we'll define it as difference in efficacy per unit difference in cost. So a drug based on this equation can have substantial benefit and still have poor value if it costs a lot. And a drug can have negligible benefit and yet have good value if its cost is low. So value does not necessarily mean magnitude of difference in clinical benefit. It also is related to cost. So the question is, how do we improve value then? So based on this equation, there are two ways to do that. We can work on the numerator, benefit. We can make sure that our treatments have larger benefit, or we can work on the cost, the denominator part of the equation. So let's touch upon it a little. Let's talk about the denominator. What can we do about the cost of cancer drugs? So we all know, we don't need to repeat this, that cancer drugs are getting truly expensive. So why are they expensive? Why are cancer drugs very expensive? Is it due to high R&D cost, the cost needed to develop a cancer drug? Because that's the justification that we see often, that cancer drugs are expensive because the cost of research and development is so high. And at the same time, we also hear sometimes that cancer drugs are actually cheaper in LMICs. We hear this in the West. People keep saying that cancer drugs are quite cheap in low and middle income countries. So that should not be a problem. So first, let's tackle that question. Are cancer drugs cheaper in LMICs? And Dan Goldstein and his team, they did a very nice research where they compared cancer drug prices in several countries, including India, and they compared that with other high-income countries like UK, Australia, USA. And what they found was, yes, of course, the drug prices are far lower in countries like India than what they pay in countries like US, UK, and Australia. But if you compare that with the GDP of the country, with the per capita income of the country, then it is far more expensive. It is far more, in terms of per capita GNI, it is, as you can see in the second graph, India has a very high percentage, very high number compared to other high income countries. So if you compare with person's income, what they are paying as a percentage of their income or as a percentage of the country's wealth, then low income countries are actually paying far more than the high income country counterparts. So the argument that cancer drugs are cheaper in LMICs is wrong. And that's why when I had the chance to write an editorial for this paper, I said cancer drugs in low income countries, cheap, but unaffordable. Yes, it is cheap, but it's not affordable. So that's one misconception that we have to clarify, that yes, drugs are cheaper, but it's not affordable. And the second part of the question, what about the R&D cost? Is it justified that cancer drugs cost so high because the R&D costs are high? And if we try to control the drug prices, is there a real threat that we are not going to get newer cancer drugs? Let's see whether that's true. This was an important paper done by the WHO group, published in JAMA Open in 2019, where they looked at several cancer drugs and found how much money was spent in R&D and how much they recouped after the drug was approved. And so they found that for every dollar that was invested in R&D, they got $14.5 in return on average. That's a good amount of return. Even Warren Buffett will not have such amount of return for every dollar that he has invested. And the median time to fully recover the maximum possible risk-adjusted cost of R&D was 5 years. So that means, on average, every cancer drug R&D cost has been recouped within 5 years. So anything that they earn after that is just profit. So there is high amount of profit. We cannot say that cancer drug costs are justified because of R&D. So what can we do about it? How can we reduce the price? Of course, there is price negotiation and price transparency. So, price negotiation, this is important for countries like US that does not do price negotiation. But there is also the issue of price transparency. We actually do not know how much we are paying. Like, we do not know what country is paying what amount for which drug. And it differs from countries to countries, institutions to institutions. And that is one area where we can work, but all of us have to collaborate. And price transparency will help in price negotiations. In this study published in Lancet Oncology, they looked at price of 31 cancer drugs, and they found that the price the countries were paying across these 16 European countries, Australia and New Zealand, the difference of the same drug price between the highest priced country and the lowest priced country was somewhere from 28% to 388%. That's a huge difference in the price for the same drug based on which country is paying it. If there was price transparency, then probably they would have negotiated better. Then let's talk about universal health coverage. I think that is important because studies have shown that governments, although they provide an average of more than half of a country's health spending, still patients are paying out of pocket. More than 35% of health spending is coming out of pocket. But studies have shown that when a government is buying these drugs, they are paying only 1.1 times the international reference price. But when private sector is buying the same drug, they are paying from 9 to 25 times the reference pricing. So it's always cheaper when the government is buying the drugs. It's not cheaper when the patients or the private institutions are buying the drugs. Therefore, there is an importance of universal health coverage where the government is, when the government is buying the drugs and not the private sector. And therefore, there comes the role of health technology assessment and price regulation. So what's the difference between having health technology assessment body versus no? So let's talk about, let's compare US that does not have a STA body with Canada, US versus Canada. So we published this paper last year. We compared, we saw what's happening in Canada with the Canadian Agency for Drug and Technology in Health that does price negotiation. And we compare our findings with the findings from the FDA. And in this table, we compare and see that more drugs that are being reimbursed in Canada, they have higher magnitude of benefit. They have better OS data. They have higher quality of evidence than the drugs that are being approved in the US. And similarly, this other study compared US with UK. And again, they found that the launch price was 42% higher in US. And the average increase in price per year was 8.8% in US versus 0.3% in UK. So I think price negotiation is important. There should be a health technology assessment body to make it happen. Having STA matters. Then there are other several approaches like public-private partnerships, the responsibility of the industry, philanthropy, like we know with the GLIVEC program, how it was accessible all over the world, free of cost mostly. And then participation in clinical trials. There are several approaches, and I'll not have time to discuss each of them. But one quick note about compulsory licensing and importing of generics. In this JGO paper, they listed some of where this, based on the TIPS agreement, they tried to issue compulsory licensing. And there is an example of India where they granted compulsory licensing for sorafenib. And this alone apparently saved $140 million in 5 years. So I know this is like the last shot. This cannot be used very often, but it can be used as a negotiating chip, maybe. That if you don't issue us, then we are going to use compulsory licensing. But I would also like to make a quick note about quality of drugs. This is an important problem in our part of the world. We see such type of news all the time. When the patients are not responding to a drug, we have to ask whether it is disease progression or whether the drug is fake. And this is an actual issue. The problem of counterfeit medications. And in LMICs, studies have shown that the prevalence is up to 28.5%. And this actually increases the cost of care because access to counterfeit medications is worse than not having access because we are paying for something worse than a placebo. So that is my talk about the denominator. Now let's talk about numerator, benefits. And you have heard several things about how to measure benefit and how we identify good value drugs from poor value drugs. I don't want to repeat the same discussion again, but all this discussion is about access to new cancer drugs, access to cancer drugs. But we need to make sure that this is access to meaningful cancer drugs. We need access to meaningful cancer drugs, not just new cancer drugs. And there is a difference between that. So we wrote this paper about cancer groundset, and it's remarkable that all three authors, we are here today. In that paper, we write that lack of access to new cancer drugs, it should not detract us from lack of access to meaningful cancer drugs and curative services like surgery or radiotherapy. Just to give an example, lack of access to trastuzumab for breast cancer or immunotherapy for melanoma is not the same as lack of access to neratinib for breast cancer or regorafenib for colon cancer. So we should not just be asking for access, we need to ask access for meaningful cancer drugs. That means we need to prioritize, and how we make this prioritization based on several factors that we have discussed in this meeting. I want to highlight just a couple of points. One is about statistical significance versus clinical meaning. We all worship at the altar of p-value less than 0.05, but we need to be really careful to differentiate that from clinical meaningfulness. Just one example for your future reading, this paper we wrote in Nature Reviews about 2 recent breast cancer drug approvals. I'll discuss about one of them. It's the neratinib trial called the NELA trial. This was approved by the FDA first. So why? Although they did not write it as not, they wrote it this way. A numerical difference favoring, they observed a numerical difference. Statistical significance was not achieved. That is an example of spinning, but they approved it based on PFS only. And the median PFS was 5.6 versus 5.5 months. I did not make a typo here. That is the data. 0.1 month of difference. That is literally 3 days. That means if your CT scan was delayed by a week, it would have been 7 days. That's less than a week. But the p-value is significant. 0. There are 2 more zeros before 5. So we need to be sure that we're not just chasing a p-value. But measuring magnitude of benefit is tricky. It's not just about the median. There is hazard ratio. Sometimes we need to use root mean square times. Quality of life matters, toxicity. So how do we do that? There are ASCO value frameworks, NCCN blocks. But the most commonly used one, and the one that I like, ESMO MCBS. Disclaimer, I am in the ESMO MCBS working group, so I have to like it. But what about the hardwired bias? Because this is our ESMO MCBS one example among different forms. This is form 2B, and we look at hazard ratio, we look at difference in medians, but there are also other parameters that will matter. And we actually wrote a paper about it, highlighting all the issues that can go into a trial design that can bias our magnitude of clinical benefit. To list point-wise, there are several things that we need to consider. Was the trial stopped early, crossover, substandard control arm, surrogacy. And we have talked a lot about these issues today, and I'm running out of time already. But one thing I want to highlight is, does PFS correlate with quality of life? We have talked that it does not correlate with survival all the time. It is important to remember that it does not correlate with quality of life either. In our recent paper, just a couple of months ago, we looked at quality of life outcomes in cancer trials. And it is important to highlight here that there are several trials that improve PFS, does not improve OS, and in fact worsens quality of life. So it's better not to have access to those drugs. So not having access is not always a bad thing. And the other thing I want to highlight based on this paper is sometimes we are misled by seeing chemo-free interval because it's an oral drug, targeted drug. Chemo-free treatment. Chemo-free does not mean toxicity-free. Targeted drugs will have toxicities, and we saw that their quality of life outcomes are worse. One important example, again, recent example, atezolizumab in triple-negative breast cancer, how they mislead us. There they write their statistical principle clearly that they would examine intention to treat population, PD-L1 population if intention to treat is positive and intention to treat is negative. Even then they do subgroup analysis against their own statistical principle, and the FDA approves this at first. And there are several things to this story, but just a brief note, we write a paper in JAMA Oncology saying that this drug should not be approved, and the overall survival results were negative. The confirmatory trial turns out to be negative, and FDA actually withdraws this indication. But I'm just trying to link this to the Indian context, because we always think in our part of the world that if a drug is approved by US, then that's a drug that our patients should start getting immediately. But the US withdrew this indication. But after this indication was withdrawn, I heard that Dr. Amol Akhade, he told me that this drug was still being used in India. Like when it gets approved, it starts being used immediately. When it gets withdrawn, it does not get withdrawn immediately. So we wrote this paper together, Dr. Amol Akhade, Vauna Shiroi, and I. in Lancet Oncology. And this actually was discussed a number of times in other forums. And I hear that now it has been withdrawn from India as well. So we should really deprioritize low value drugs. I'm really towards the end. Just to give an example of how bad the situation is, cabozantinib, hepatocellular cancer, this research showed that the incremental cost effectiveness ratio was more than $1 million. And when they considered $200,000 per quali as the threshold, which is not our threshold, but when they considered $200,000, there was no scenario in which this drug was cost effective, even with 10%, 20%, or 30% discounts. Just to give you how bad the situation is, they said that for $800,000 per quali of threshold, for this drug to be cost effective, the price had to be $50 per pill. Currently, it costs $734 per pill. How much discount can we ask? It costs $734. You go to buy a coat, they say $734. Will you be able to say, can you give it for $50? So I'm disappointed, and that's why I do not buy that hype that biosimilar is going to solve all our problems, generics. How much low are they going to cost? 50% low? Even then, it's not going to be cost effective. 70% low? How much discount are we going to ask? Anyways, a final word about avoiding overtreatment. I think we're treating too many patients at too high a dose for too longer duration at too frequent intervals, especially with immunotherapy. So that is another way in which we can improve the value of our treatment. But a final word of caution is that value-based pricing in isolation may not necessarily be the final solution. For example, if we did discover something that is going to cure cancer, then value-based pricing will mean that it can cost infinite amount of dollars and it would still be low value, but we cannot afford that. So that in isolation is not a solution. So we should all be aware of these issues. And a final recommendation is to please go through this paper that Dr. Booth and I wrote together, in which we'll outline all these threats and ways to solve them. Thank you.